crayons go on vacation? Where do crayons go on vacation?
Colorado.
To the Wax Museum. Why did the skeleton ride the roller coaster? Why did the skeleton continue to ride the roller coaster? Why did the skeleton continue to ride the roller coaster? He didn't have the guts to quit. Okay. What do you get when you cross a vampire with a snowman? The spirit of Halloween. Frostbite. Very, very well done. Richard really liked that one. That was a good one, actually. All right. Good, clean fun. All right. Here's where we are. So let's refresh where we've been. So we've been talking about hypersensitivity. Who can explain to us what hypersensitivity is? Normal response overreacting. I would agree. That was option A. That would be perfect. But if the words were a little different than that, could you explain it in a different way? You know, sometimes in classes, we get so far into the weeds, and you can explain all these mechanisms of, the CD4 role and how it communicates with this MHC class 2, right? And then allergies are tied to IgE. But then someone asks a simple question like, what is hypersensitivity like? There's 4 classes, right? There's 4 different types. If you give me some examples, I can tell you what they are, but I don't actually really know what it is. So let's pause for a second. What the heck is a hypersensitivity? Richard's definition is spot on. But what does it mean to you?
An abnormal immune response to an irritant.
Okay, an abnormal immune response
Or
to an irritant. I like the first part. I mean, again, there's, we'll massage it as we go. An abnormal immune response. I like that. To an irritant, it could be to like an allergen if it's a type 1 hypersensitivity, or if there's self-reactive antigens, or if there's, self-reactive clones that see cell tissue, then maybe that could be an abnormal response to an irritant. Maybe that tissue is being considered the irritant, so maybe in that way, yeah.
I was going to say pathological activation of the immune system.
A pathological activation of the immune system. So it's abnormal. So the immune system is activated abnormally. I like that. Yeah, that's good. I mean, is it a disease? Is hypersensitivity a disease?
Yes.
Yeah. I mean, none of you actually said that the first day of class. When we're talking about examples of diseases, no one said hypersensitivity class 3, right? You guys remember that? You're talking about things like diabetes, right? So you said things like multiple sclerosis, cancer. Nobody said type 4 hypersensitivity, right? But is it a disease? Yeah. Is it a pathological condition? Yeah. So how does it show up? How does it happen? How does a hypersensitivity happen?
Like failure of central tolerance or peripheral tolerance.
Failure of central tolerance or peripheral tolerance? Agreed. Does everybody know what that means? From the last exam, hopefully you do. So these are, we say that the system is leaky, meaning that we've got self-reactive clones that make it out into the body, and then they do bad stuff. That's the disease. And those self-reactive clones, if they're a B cell origin, they should have been eliminated in the bone marrow, right? Something like, I can't remember the exact numbers now, but it was something like 90%, right, are signal for apoptosis because they're self-reactive, or they have the potential to have self-reactivity. So only 10% of those B cells make it out to the periphery. And then the T cells, it's a little bit better. I mean, something like 95%, I think is what we said. 95% of T cells either get eliminated in the thymus or they're eliminated in the periphery, right? But B cells don't have any peripheral tolerance mechanisms, just T cells. So if that system, if that fence perimeter is not tight and something gets through, we say the immune system is leaky. It allowed for a self-reactive clone to sneak by. And now it's out there doing pathological damage. It's triggering hypersensitivities. It's triggering an abnormal response, okay, or a hypersensitive response to a normal immune function. Does this all make sense? Okay, I don't want to get too far into the weeds without backing up and going, okay, where the heck are we? Because we're going to talk about two kind of classic examples, and that's why it was good to hit the pause button on Monday, and then we're going to come back here, because we're going to talk about transplant rejection, finish out type 3 and type 4, and then we're talking about two examples with lupus, and then with rheumatoid arthritis. Type 3 with lupus, and a type 4 with rheumatoid arthritis. And when we're so deep into the granularity of our mechanistic pathways, a lot of times students get lost. And I've heard some of you going, so I don't really understand like how this happens. Some of you said, I don't understand like why does this take place? So does that explain a little of the why or how? Now the why and the how are somewhat related. Okay, so we learned about central tolerance and peripheral tolerance with B and T cells in the last unit. And when that goes awry, you have a disease state and it leads to hypersensitivity. Okay. So transplant rejection. Transplant rejection is a condition where you have incompatibility of the host. Transplant rejection is considered a type what hypersensitivity? What type of hypersensitivity is transplant rejection? It's a type 4 because we have what cell type involved? T cells. Because we have T cells that are engaged, we're labeling this as a hypersensitivity type 4. Okay? And so you've got donor tissue. Let's pretend that you're going to give a kidney from one patient to another. You have two kidneys, right? Kidneys are often transplanted because you can survive just fine on a single kidney, and then you can donate that spare kidney, if you will, to somebody if necessary. Often it happens in families where there's a kidney need, and they'll do a kidney transplant from brother to sister, or father and mother to offspring. But every now and then we've got, or oftentimes we have incompatibility of the allograft. We have incompatibility between one tissue to another. And allografts, when we talked about wound healing, we talked about allografts with wound healing, cadaveric tissue. But what was the secret of why it's not really a problem to transplant skin from a cadaver to skin to a patient or a recipient? It's acellular. You take the cells out, the nucleated cells express these major histocompatibility complexes on their surface. We talked about those, type 1 and type 2. Those are the labels that tell your cells that they belong to you. So if you take a skin graft out of a cadaver and you decellularize it, you eliminate all those MHC complexes, okay? But if you take a functional kidney tissue and you transplant it from one patient to another, you absolutely have nucleated cells. And so you can have one of two problems happen. You can either have a direct pathway stimulation, or you can have an indirect pathway stimulation. In both pathways, regardless of which one is triggered, it's essentially you're rejecting the tissue based upon MHC class recognition. So if we look at our direct pathway down here, in the middle panel, we're going to go this way. So the direct pathway, we've got an antigen-presenting cell that's in the graft. So that's the tissue that's being transplanted. And it's expressing either a type 1 or a type 2 MHC complex. If it's a type 1, you remember, it actually triggers a CD8 cytotoxic T lymphocyte trauma or damage. Or if it's a MHC class 2, then it's the helper T cell, the CD4 positive T cell, that actually recruits an inflammatory response. Either pathway from the direct stimulation causes trauma to the blood vessels, leading to endothelialitis, and to the renal tubules, which actually closes them off. Okay? If we look over at the indirect pathway on the right side of the slide and coming down, this pathway really exclusively utilizes the CD4, the helper T cell. And so because the helper T cell or the cytotoxic T cells being used, we typically refer to transplant rejection as a type 4 hypersensitivity. Okay? So what can we do about this? Well, as it relates back to our previous unit, if you recall, we actually take a co-stimulation event over here to make effector T cells. And so when this IL-2 signal is released and binds to itself via an autocrine response, or an autocrine co-stimulation event, you guys remember this? Then this stimulates the production of effector T cells and memory T cells. Well, we've got a molecule that was discovered many, many years ago, known as cyclosporin. And it was actually discovered in Norway in 1969. And it was isolated from a fungus by a Norwegian scientist, and I can't pronounce their names, you'll have to Google it, okay? Hardenvidia. Wow, I think it's pretty close, actually. None of you would know, right? I think you're like, sure, whatever. So cyclosporin is a drug that's a transplant rejection drug that will deliver in the clinic. And what it does is it blocks interleukin-2 activity. And so by delivering this fungus-based drug, you can actually prevent IL-2 release, and you can render more successful outcomes of these transplants. Okay, so here's an example of how current medicine, in the 1960s, 1969, but it's relatively new, okay? Penicillin was hundreds of years old, but cyclosporin, back in the last millennium, I know, but, it is older than me, just for the record, okay? Cyclosporin discovery is older than me. But pretty relatively young in the spectrum of medicine, and we've already discovered a fungus-based medicinal compound that can block IL-2 activity and render these allografts more successful. Kind of cool, okay? So if you don't have cyclosporin on board, or if you have cyclosporin on board, but if you go back to the previous slides, cyclosporin activity is really rendering CD8 pathways. So the CD4 pathways, the helper T cell pathways, are still operational. And cyclosporin really only renders the CD8 co-stimulation event to be mitigated. So you can still have the opportunity for long-term rejection, but it's delayed, okay? So if you have the rejection, what takes place? So these are histological samples, okay? Hematoxylin eosin stain images. Let's go ahead and dim the lights. And we're going to look from left to right. And we're going to talk about this kidney allograft. So over on the far left, what you can appreciate is what looks like a normal glomerulus, right? So we've got the glomerular profile right here. And as you progress over here, you can see that now it's scarred and things are problematic. So the damage that takes place in panel B, the one right next to it, you see all the new infiltrated inflammatory cells, right? So this is acute cellular rejection of the kidney allograft with inflammatory cells in the interstitium and between the epithelial cells. What early responder inflammatory cells do you think all these purple nuclei represent? Neutrophils. Very good. Okay? So you're already utilizing the stuff that you learned in the first unit and you didn't even realize it. Right? I mean, that's how simple it's going to be. If you use it, you'll continue to remember it. Okay, so now you can see from here to here, this is early phase, quote unquote normal. It's actually still diseased. This would be early. The reason that you know it's diseased is, see this white space right here, which is Bodeman's capsule? It should really be about twice the thickness. And so you can see in areas where it's almost gone. So I said this was normal, but it's not as bad as this, but I would argue this isn't actually normal. This is early phase rejection happening, where you're getting a lot of swelling of the tissue in the interstitium. But here you can really appreciate that now you've got infiltration of these inflammatory mediators, which you do not see on the far left panel. So in this second left image, you've got some hyper rejection of cellular tissue. If we go over to C, the third one from left to right, now we're starting to see a humoral rejection of the allograft by vasculitis. And so what we have here is a blow up of one of the blood vessels, and we've got a thickening. This is the smooth muscle cells right here. So we got a thickening of the smooth muscle cell. This is all intravascular debris. So this should be a white opening. Right here you can see that there's a little sliver of a white opening. So this is a blood vessel. This is the glomerulus. This is the glomerulus. This is a blood vessel. This is a blood vessel. So now you got vasculitis, and you're basically blocking the lumen with all of these inflammatory mediators, and you've got these complexes that are forming based upon antibody recruitment. Over far on the right, we've got graft arteriosclerosis. So the vascular lumen in this panel that's been infiltrated with all of these inflammatory mediators, now those those inflammatory mediators are starting to dissipate, but you're left with an arteriosclerotic lesion. So you have scar on the inside of the blood vessel. And the only lumen that's open is this little sliver of white where actually blood flow can pass through. And so now you're basically shutting down the kidney. Okay, so now the graft itself thromboses over. That means it clots. And if it thromboses over or it clots, you get no more blood flow and you have organ death that takes place. Okay, so that's how these grafts, this is a kidney. It would be the same thing if it was a transplant of any other tissue. Skin would be the same situation. Okay?
So C and D aren't the glomerulus? It's just
No, C and D are looking at blood vessel.
vessels? Okay. But A
C and D are looking at blood vessel, and A and B are looking at the glomerulus. Okay, transplant rejection. So let's talk about two examples of autoimmune diseases that I want to characterize in more detail. One from type 3 and one from type 4. But before we go there, this is kind of how I open the lecture today is, so what's going on? What does this mean? How did we get here? So we all agree that we're talking about a disease, right, a pathology. We have all gotten to the point where we agree that this is a normal process. This is the immune system that normally should be operating in a healthy way to combat infectious agents. But here, it actually went awry, and it's actually targeting yourself. So you're hypersensitive to your own tissue, right? So we say, in the first bullet point, we have the breakdown of self-tolerance mechanisms. And so we said appropriately, we got central tolerance and peripheral tolerance for T cells, and something went wrong there. And then for B cells, we only have central tolerance, but something went wrong for B cells. So either we're making antibodies from B cells that came out of the bone marrow that are reacting to your own tissue, or we've got T cells that came out of the thymus that are misbehaving because they're targeting and killing your own tissue. So we got the breakdown of self-tolerance mechanisms, and how does this happen? Right? This is the age-old question of how did we get here? And so this is the nature versus nurture argument. In the literature, there is evidence for both triggers that will cause the breakdown of self-tolerance mechanisms. Right? And we're always looking for genetic links. And so people say, oh, so-and-so has MS. Well, golly, is it genetic? Like, did they get it from mom or dad, or is it run in the family? That's always one of the questions. It doesn't matter what the disease is, it seems, right? So-and-so has cancer. Oh, gee whiz, is cancer run in the family? So we're always kind of looking for these genetic links. And there are genetic links. And people are susceptible to having self-tolerance mechanisms break down. Okay, we don't know exactly how that takes place. It's not fully elucidated, but we know that there's a role there. We also know that there are some environmental triggers. And so I'll give you an example. What are those environmental triggers? Some are going to say too much school causes all sorts of pathologies. Okay? Well, there's some actual truth to that, right? Some of you are laughing. Stress. Stress causes an increase in glucocorticosteroid release, which actually lowers immune function. Did you know that? So how many of you seem to always get sick right before a big exam? Right? There are a couple of snifflers in here last week, I noticed that. How many of you get sick right before a big exam? Or if you were ever competing, you ever in a competition and you can't sleep the night before you wake up and now you got a scratchy throat, and you're like, what the heck is up with this? Just bad luck, right? Well, so there are some connections between these environmental triggers, like stress could be triggered by something that's outside of your body, for example. You know, isn't stress an internal response? You know, well, yeah, but usually you're responding to something that's, you know, your body's interpreting. So stress causes corticosteroid upregulation, which actually lowers immune function. And that has been well described in the literature. Okay? So that's one. Another one happens to be UV radiation, believe it or not. There's links of UV radiation to all sorts of different types of diseases, not just cancer. I'm not talking about causing damage to the DNA, but UV radiation being an environmental trigger in certain types of UVA or UVB rays. And so you can look into those two examples if you would like to. But what I want to talk about here is one of our first of two final diseases in this particular lecture. The first one is lupus. And so the big issue of lupus is systemic lupus erythematosus, or SLE. And so what is it? Well, it's a disease where you're breaking down, you're targeting tissue across the body in many different systems, and you're reacting to it. Okay? And SLE is classically referred to as a type 3 hypersensitivity. So it's an antibody-mediated responder. So you're making antibodies to nuclear antigens, typically, or making antibodies to self-antigens. Oftentimes they're nuclear antigens. And either you're responding to some inheritable traits that target things like MHC class 2, your own MHC class 2, or it could be, for example, in the case of environmental that we just talked about, it could be chronic exposure or peaked exposure to certain UV radiation. And so that's why you see these two boxes here of there's some genetic component, likely something going on with class 2 MHC, and then there's some environmental triggers such as UV light that causes the body to respond to self-antigens. Usually they're nuclear antigens, okay? And because this is MHC class 2, in the case of the genetics, is it target a single tissue? No, it's everywhere. Okay, now there are certain areas, the skin tends to be a highly susceptible organ for the triggers of lupus and the manifestations of lupus. And they get kind of a lot of these rashes and these sores and these lesions that take place. But what we've got here is activation of helper T cells and B cell specifics for self-antigens, leading to an IgG autoantibody production. Now, some of you are going to say, okay, well, we've got helper T cells involved, so why isn't this a class 4? Well, in the case of this example, remember how I said these are just buckets that we label? So you will see in the literature some textbooks referring to lupus as being a type 4 hypersensitivity because there's a T cell involvement. But for our purposes, because the activity is initiated primarily through IgG, which is an antibody, we usually still classify this as a type 3. So on the exam, if you see lupus, you would classify it as a type 3. But I just want you to understand why you might see it somewhere else if you do like a Google search as a type 4 hypersensitivity. Does that make sense? So we're classifying it as type 3. Your textbook calls it a type 3 because of the IgG role. Okay? Then you get these immune complexes and these autoantibody mediated tissue injuries that take place with lupus. So we say that there are really 4 main types of lupus. We're characterizing the most aggressive form, which is SLE. This is systemic, it's all over. Well, there are a couple that are less severe, like cutaneous, where it only attacks the skin. We've got drug-induced There's certain drug chronic uses that can trigger autoimmunity to take place. Typically, they're not prescription medications. They're illicit medications that are being used in inappropriate ways. And then also fetal. Believe it or not, there's a situation with fetal-induced, and there's some belief that maybe that might be tied to mother versus embryo, where the mother is kind of responding to tissues that are growing in the womb. And there are some immune messages that are taking place that cross the maternal-fetal barrier, the placental barrier, and now you get these autoantibodies inside of the fetus. But basically with SLE or systemic, you've got a chronic multi-system inflammatory disease. So you're causing inflammation of all these tissues. It's one of the more common autoimmune diseases. That's why I'm highlighting it. It's also a little controversial on whether it's a type 3 or type 4. That's why I wanted to bring it to your attention. Women are more susceptible to men, about a 9-to-1 ratio. Don't know why, okay? Is that fair? No. It is definitely not gender equal disease, okay? UV light exaggerates their conditions. So if you've got a lupus patient that's having some rash formation on the face, and they go out in the sun, it'll flare up aggressively. Okay, so UV light will exacerbate the situation. So let's look at some clinical signs or examples. This is a younger patient, obviously. I think some of these pictures are interesting that they block out, the eyes, because like if she was in this classroom, you'd never know it was her, because her eyes are blocked out, right? But there you have it. So that's how we have to do clinical photography. But you can see this classic rash formation on the bridge of the nose. They call this a butterfly rash. This is very indicative of SLE. It's also indicative of cutaneous lupus, where it's targeting just the skin. So another name for cutaneous lupus is discoid lupus erythematosus. But this is this butterfly rash that they get over across the bridge of the nose. They tend to have acute necrotizing vasculitis, bless you. So they've got these antibody-antigen complexes that are forming. Remember, this is a type 3. So you got an antigen-antibody complex that forms and it gets stuck somewhere, right? It gets stuck in the blood vessel, and so that's vasculitis. But it's acute necrotizing vasculitis, meaning you get a lot of tissue that starts to die in the wall of the blood vessel, okay? You've got joint swelling because you get a lot of these immune complexes that funnel to or filter to the joint and they get lodged there. And then we've got skin erythema. Skin erythema is a word for redness, so that's what you're seeing on the mylar rash or the butterfly rash on this young patient. CNS involvement is usually due to vasculitis and angiopathy and thrombosis of small vessels in the central nervous system. Okay, so they'll get these vasculitis that takes place, but it happens all over the body, and so the small capillary beds in the brain have some of these lesions that take place. Okay, this can be a very debilitating disease. And then glomerulonephritis, right? That's another. So the classic type 3 slide that we looked at on Monday showed vasculitis, right? Inflammation in the joints with reactive arthritis, not rheumatoid. And then thirdly was glomerulonephritis. You guys remember that slide? And so the SLE patient has all three of those situations going on as a classic type 3. Okay? Questions over lupus? Okay. Yes?
I forgot, what is
Glomerulonephritis? Yeah, so glomerulonephritis is inflammation of the glomeruli in the kidney. So you remember these antibody-antigen complexes that form in a type 3? They typically float through the bloodstream and they get stuck somewhere. And they're going to typically get stuck in places that filter blood. So the kidneys filter a tremendous amount of blood, and that's why it happens in the glomerulus. Right? In the joints, that's how you manufacture synovial fluids. You filter plasma. And then obviously vasculitis will you know, you've got the complex floating right by and it gets stuck in the wall of the blood vessel. Okay, so let's talk about the last one in this particular lecture. This tends to be relatively an interesting one because a lot of us are familiar with arthritis, but we really have, in a way, 3 different types of arthritis. Okay? So let's write these down so that we don't misunderstand them. So we talked about reactive, right? And this is of type 3. You guys with me? Now we're going to talk about rheumatoid arthritis. And this is a type 4. So we're going to see T-cell involvement at a significant level. The third type, which we won't really talk about in this class, this is called osteoarthritis. And osteoarthritis is not an immune issue, really. I mean, you could probably make an argument. Osteoarthritis is the arthritis when you've got bone on bone, for example. It's a wear and tear. It's an old age type of disease, is osteoarthritis. Osteoarthritis is usually unilateral, okay? So it only happens to one side of the body. So somebody might get arthritis symptoms like in the right hip or the right knee, or if they were a pitcher, their throwing arm. Rheumatoid arthritis and reactive arthritis are bilateral. Okay, so if arthritic conditions exist in a rheumatoid arthritic patient, it's not just the right shoulder only or the right elbow. It's going to be both elbows on both sides. Does that make sense? Okay, so these immune diseases are bilateral, and the osteoarthritic condition is unilateral typically. Okay. All right, so rheumatoid arthritis, classic type 4. It's very common. About 1% of the population develops rheumatoid arthritis. I would say osteoarthritis is probably more common, but we're not talking about osteoarthritis. I just wanted to list the different ones so that you knew where this all fit. Does that make sense? And then you walk in, you're bragging about how much you know, and then someone throws you an osteoarthritis question, you don't put your foot in your mouth. Make sense? So I just want you to know comprehensively where all this fits in. So this is rheumatoid arthritis, our type 4, and it is about 1% in the population. The thought process is that T helper cells respond to some arthrogenic agent. Now, the arthrogenic agent that is most likely the culprit is collagen type 2. So collagen type 2 can be found in all sorts of places in the body, but it is actually found in the joints themselves. And this arthrogenic agent triggers an MHC class 2 response. And if you guys remember, the MHC class 2, its messenger is the helper T cell, the CD4 positive T cell. So now the CD4 positive T cell can trigger B cell activation, creating autoantibodies. It can trigger an inflammatory response, right? And it makes all these cytokines that can cause damage to the endothelium. So the type 4s, like with rheumatoid arthritis, they can get a little confusing because at the end you start seeing, oh, well, there's antibodies involved. Yeah, but the key molecule that's responsible for this whole signal is at the pivot point of the helper T cell. So we call this a type 4 because of T cell involvement, or the role that T cells play as being pivotal. It can't happen any other way unless this helper T cell is involved. Okay? So now we've got CD4 cells, helper T cells in the joint. You stimulate all of these downstream events like macrophage activation, B cell activation for the production of autoantibodies against your own collagen type 2. And then endothelial cell activation, right? Because of the cytokines that are being manufactured by our activated or sensitized CD4 positive T cell. So morphologically, what does it look like? So you got a cartoon on the left, and in the middle we've got some histology, and then on the far right we have some histology. So in the joints themselves, we get what's called synovial destruction. We get pannus ingrowth. Pannus is a word that refers to a massive synovium and synovial stroma that has a population of inflammatory cells in it. And then we'll get a condition known as ankylosis. This is from the Greek meaning bent or crooked. So that ankylosis is the stiffening of the joint because you have so much cellular debris and inflammation that's taking place there. So if you look at this diagram on the left, this is bisecting the joint. You see what's called a normal joint on your left, and we see a rheumatoid joint on the right. And in the normal joint, you should have this nice, clean surface of the synovial membrane. And over on the right side, you can actually appreciate you've got this sort of this orange highlighted region. This is the pannus. So now you've got pannus ingrowth of all this inflammatory cells, and the cartoon is highlighting like macrophages and dendritic cells, antigen-presenting cells, right? Plasma cells, all different types of antigen-presenting cells. And you get the recruitment of neutrophils, our first responders, and then you make these immune complexes because you're manufacturing antibodies. So our middle panel, if we look at the histology in the middle, we've got, this is synovial hypertrophy that's taking place. Synovial hypertrophy, where we have swollen all of the cells within the synovial space, and they've enlarged to the state where, you see where these white spaces are? These white spaces should fill the vast majority of this image, whereas the purple and the pink fills most of the images. So if you took the polar opposite, like the negative of this picture, and where all the purple and pink are was white, that's how it normally should look. So it's like flip-flop from the normal view. And then over here, on panel C, the arrows are pointing to dense lymphoid aggregates that are collecting inside of the synovium. So now you have these lymphoid aggregates, which are lymphocytes that are bundling inside of your synovial fluid. And that's all of these kind of brownish red colored aggregate tissue that's taking place. So in the joints, this is what you've got going on, but this is a systemic disease. So you're going to have similar types of lesions that happen in the blood vessels. You're going to have similar types of lesions that happen in skin. And so these patients will get these rheumatoid nodules that form on the surface of their skin. Okay? And these things are all painful because you have an inflammatory tissue. So that nodule is tender to touch. Okay? It's annoying. It's very annoying. So if we move on and we look at some of the clinical significance of rheumatoid arthritis, we've got a number of different organs that can be affected. Let me dim these lights so that we can see this a little bit better. We got a number of different organs that are affected. We've got skin, and we've got joints, and of course we have the blood vessels themselves. But the heart can be affected because it's well vascularized. The lungs and the muscles can be affected because there are blood vessels that go to all these tissues. And so if you've got these lesions that are forming in the blood vessels, they can be forming in these other tissues as well, in their vascular supply. This ankylosis is from the Greek term meaning bent or crooked. And so you can kind of appreciate in a rheumatoid arthritic hand how the hand starts to bend, because if you've got a disease happening on one side of the joint, it's pushing that finger to the other direction. Does that make sense? It's not going to be happening around the whole joint. It's happening on one side, versus versus the other side. Okay, episodic. So it occurs in episodes where it can flare up and then it'll subside. And so a lot of patients will say that cold, wet weather will aggravate their rheumatoid arthritic conditions. It usually targets small joints first and then targets larger joints. So that's why it happens in a lot of the fingers and the toes first. And then it's symmetric versus osteoarthritis, which is unilateral. This is going to be symmetric. And in 80% of the cases that we test, we see that there's some rheumatoid arthritic factor. So there's some antigen that the patient is responding to. 80%. All right, so in this x-ray, what I want you to be able to appreciate is the progression of this disease. So, you know, this is a diseased patient in both images. This particular inset is highlighting this joint right here, and the arrow is identifying a spot where you're getting erosion of the bone because of all the inflammation. So that inflammatory battle that's taking place, if it's chronic, remember we have a lot of toxic chemicals that are being released to the surrounding tissue. What's the surrounding tissue? The surrounding tissue is bone. And so that bone is going to erode over time. So that's what you're seeing kind of on this left x-ray or radiograph, is you're getting a little erosion of the bone. Further on, this is a different patient, but further on in the disease as it progresses, you can kind of appreciate the hot spots. So these areas right here that are hot spots of rampant inflammation, as things progress, create these inflammatory lesions that light up because of all of the water and all of the calcium that's being broken down as the bone erodes. Okay? So, this is the table that I alluded to that I wanted you guys to take a peek at. And I think it's a really nice summary slide on the things that we covered on Monday as well as today. So let's just take a look at it real briefly. Different textbook, but we've got characteristics down the far left column. We've got type 1, type 2, type 3, and type 4 as the columns progress. You can see the antibodies that are utilized in the first three classes. And then you can see the antigen, some characteristics about it. You can see some notification about how it mechanistically is induced, whether it's antibody versus T cell. And then there are some classic examples across the bottom. You can see SLE is characterized in type 3, and then some of the classic type 4 that we talked about, like poison oak and poison ivy, are in the type 4 category. Now, of course, these are just examples. So is transplant rejection, you could write transplant rejection right here, right? So that's an example. What are some of the other type 4s that we talked about on Monday that you could write down on this table? You guys remember? We had Hashimoto's, we had diabetes mellitus type 1, right? We had MS, multiple sclerosis. Who said celiac? There's celiac. Okay, Crohn's. Those are all types. So they all don't fit in the box, but you kind of get the idea. So we're just highlighting a number of these. But all of these diseases, some of which, like diabetes type 1, somebody said diabetes our first day of class. So you were characterizing a type 4 hypersensitivity, you just didn't realize it, right? You're using that as an example. Okay, questions? Yeah.
I noticed on type 4, and you mentioned this Monday, but I don't think I can get it right, but the poison ivy is on type 4 versus 1. It's not an alerted response. Is that
Yeah.
like reread my notes? Why that is?
Why that is?
Yeah.
So type 4 hypersensitivities involve T cells. And so like poison oak and poison ivy are like a contact dermatitis, where you're actually harboring a T cell response, not necessarily an IgE response. That's why it's not a type 1. Yep, great question. A very common question.